I want you to picture a specific scenario for a second. It's a real medical mystery. Imagine you are in the absolute prime of your life, somewhere between 30 and 50 years old.
Right.
You're not a kid with a developing immune system, not elderly with a fading one. You've been healthy your whole life. No chronic issues. You're working, paying the bills. You are, for all intents and purposes, bulletproof.
It's the demographic that is supposed to be, the safest from a health perspective.
Exactly. And then, with just no warning at all, the floor drops out. Your body just stops defending itself.
Wow.
And I don't mean you catch a bad flu. I mean, you start getting infections that a healthy human body should just shrug off without a second thought. Serious disseminated infections, the kind that land you in the hospital.
That is a terrifying prospect, to go from healthy adult to critically immunocompromised.
With seemingly no trigger. And that is exactly what we are unpacking today. We're doing a deep dive into a condition formerly known as Adult-Onset Immunodeficiency syndrome.
And you have to stop right there.
You do, because I can hear the gears turning in everyone's head. You hear immunodeficiency, and your brain immediately auto-completes to something else.
Right. It sounds like a synonym for AIDS, which is caused by the HIV virus. And we need to be crystal clear right out of the gate. This is absolutely not HIV/AIDS.
It's funny because even in the research, half the literature starts with that exact disclaimer. It's the elephant in the room.
It has to be. The confusion is understandable because the outcome looks similar on a chart. Both conditions lead to a patient being vulnerable to what we call opportunistic infections.
Bugs that only hurt you if your shields are down.
Exactly. But the mechanism how the shields go down is completely different. HIV is a viral contagion. You catch it. Adult-onset immunodeficiency syndrome. It's not contagious. You cannot catch this from anyone.
Which is a huge, huge distinction. So if it's not a virus attacking the immune system, what is it?
It's an inside job. It's an autoimmune condition.
Okay, so the call's coming from inside the house.
Precisely. And our mission today is to figure out why the house is suddenly attacking its own security system. We've combed through the medical literature, the case studies.
And we want to separate the media sensationalism, and believe me, there was a lot of it, from the biological reality.
And honestly, the biological reality is fascinating enough without the hype. It forces us to ask some really uncomfortable questions about how our immune system actually works.
It does. When you look at a rare edge case like this, you aren't just studying a disease, you're studying a loophole in human biology.
Right.
So let's get into the mechanics of this loophole. In a standard autoimmune disease, like lupus, the body attacks joints or organs. But here you're saying the body's attacking its own immune system. How does that even work?
It all comes down to signaling. In this syndrome, the patient's body starts producing massive amounts of anti-interferon-gamma autoantibodies.
That is a mouthful. Let's break that down. Autoantibody.
Auto means self. Normal antibodies are the good guys. They're the homing missiles your body makes to lock onto viruses.
Yeah.
Autoantibodies are defective missiles. They lock onto your own proteins. In this case, they're targeting a protein called interferon-gamma.
Interferon, it always sounds like some kind of sci-fi shield generator to me, but in the body, it's more like a communication line, right?
That's a great way to put it. Let's use a military analogy. Your immune system is a fortress. You have foot soldiers, the macrophages, and their job is to go out and eat the enemy bacteria.
Okay, the Pac-Man cells.
The Pac-Man cells.
Yeah.
But they need orders. They need a general to tell them, hey, we are under attack, turn on your weapons.
And interferon-gamma is the general.
Exactly. When a cell spots an intruder, it releases interferon-gamma. That signal screams, wake up, attack. It activates the macrophages to kill whatever they've swallowed.
So in these patients, the body produces these autoantibodies.
And those autoantibodies are like mutineers. They tackle the general, gag him, tie him up. The signal never goes out.
Wow.
So you have these foot soldiers, the macrophages, standing right next to the bacteria. They might even swallow them. But because they never get the order to kill, the bacteria just sit there inside the cell multiplying.
That is incredibly unsettling. It's not that the army is dead like an untreated HIV.
No, not at all.
The army is there. They're just waiting for orders that never arrive.
Correct. And that specific failure makes the body vulnerable to a very specific type of enemy, intracellular pathogens. These are germs that have evolved to hide inside your cells.
A healthy person fights them off easily because the general spots them.
Right. But without that signal, These specific bugs just run rampant.
And that explains why the infection is disseminated. It's not just a localized thing. The system-wide coordination is gone.
Exactly. The alarm wires have been cut.
Okay, so we understand the mechanism, this mutiny against the general, but this is where the story gets really weird for me. The who is just as baffling as the how.
The demographics are incredibly specific.
Yeah, it's not random. This condition is overwhelmingly found in Southeast Asians. We're seeing the majority of cases in Thailand, Taiwan, Vietnam, and among immigrants from those regions.
Yes. And combined with that, we have the age factor. The average age of onset is 30 to 50.
See, that's the part that trips me up. Usually, if you have a genetic problem with your immune system, a primary immunodeficiency.
You know about it when you're a toddler.
Right, you're the kid who's always sick.
Exactly. Primary immunodeficiency is almost always present in infancy. To go 40 years with a perfectly good immune system and then have it suddenly collapse, well, that implies this isn't just a simple genetic error.
But there is a genetic component, right? The notes mention HLA genes.
There is absolutely a genetic component.
Mm.
The research shows a strong link to specific HLA genes. These are the genes that help your immune system tell the difference between self and foreign.
So the blueprint for this is there.
It is. And there's also research pointing to a gene called SERPINA1, which is involved in controlling inflammation. But here's the paradox, and this is what drives researchers nuts. Even though it's clearly linked to genetics,
Yes.
the disease is not heritable.
Wait, run that by me again. It's genetic, but not hereditary.
It means it doesn't pass down directly in families like, say, cystic fibrosis does.
Yeah.
You don't see a clear family tree of grandma had it, mom had it, now I have it.
That seems like a contradiction. If it's in the genes, why isn't it running in the family?
It suggests that genetics are necessary, but not sufficient. Think of it like a loaded gun. The genetics, being Southeast Asian, having those HLA alleles, that loads the gun.
Okay.
But a loaded gun can sit on a table for 50 years and never go off.
You need a trigger.
Exactly. You need something to pull the trigger. The theory is that this is an interaction between nature and nurture. You have the genetic susceptibility, and then halfway through your life, you encounter an environmental factor. Maybe a virus, maybe a bacterial infection.
And that trigger event confuses the immune system just enough to start making those autoantibodies.
Right. And once those autoantibodies start forming, they block the interferon-gamma, which lets infections take hold. And the cruel irony is that the more infections you get, the more your immune system tries to activate.
Which might just stimulate more autoantibody production. It becomes a vicious cycle.
It's the two-hit hypothesis. Hit one is your DNA, hit two is the environment, and you need both.
And that would perfectly explain the age of onset. You need time to stumble across that environmental trigger.
It might take 30 or 40 years before you encounter the specific thing that sets this all in motion.
That is both fascinating and slightly terrifying. Makes you wonder what other triggers we're just waiting to walk into. But let's ground this. What does this actually look like for the person going through it? Because this list of opportunistic pathogens is, well, it's a horror show.
It is a brutal clinical picture. Patients are flooded by germs that exist everywhere but usually don't hurt us.
I saw salmonella on the list, and I thought, okay, food poisoning, but it's not just food poisoning here, is it?
No, this is non-typhoidal salmonella. But in these patients, it becomes invasive. It gets into the bloodstream. It causes sepsis. It is life-threatening.
And that's just one of them.
Right. The hallmark infection is actually non-tuberculous mycobacteria. These are cousins of tuberculosis that live in soil and water.
Okay.
If you or I breathe them in, our macrophages eat them and destroy them. Done. But for these patients, the macrophages eat them and then just sit there. The bacteria multiply inside the cells, causing massive infection.
And physically, what are the symptoms?
It often manifests as generalized pustular psoriasis.
Yeah.
So we're talking about widespread, painful skin lesions, fevers, wasting away. The lymph nodes swell up because they're packed with infected cells that can't clear anything.
And this leads to a diagnosis problem. I read that one physician noted how often this gets confused with actual tuberculosis.
It's a tragic masquerade. A patient comes in, maybe from Thailand or Vietnam, coughing, losing weight, swollen lymph nodes. The doctor does a scan and sees granulomas in the lungs. It looks exactly like TB.
So they start TB treatment.
They start standard anti-TB drugs.
Yeah.
But the patient doesn't get better.
Wow.
Or maybe they get better for a week and then crash again.
Why?
Because it's not just the bacteria. It's the immune system failure, allowing the bacteria to thrive. You can poison the bacteria, sure, but if the body can't clean up the mess, you're fighting a losing battle.
That must be agonizing, to be treated for the wrong thing while your body is just failing. So once they finally realize what it is, What can they do? Is there a cure?
There isn't a cure in the sense of a magic pill. You can't just give them interferon-gamma injections because, remember,
Body's making antibodies that will just neutralize it instantly.
exactly, it's like pouring water into a bucket with a giant hole in it.
So it's all about management.
It's a two-pronged war. First, you have to aggressively treat the infection itself. Long-term antibiotics, sometimes for years. But you also have to stop the mutiny.
The notes mention rituximab. Now, I know that's a serious drug. It's used in chemotherapy, right?
It is. It's a monoclonal antibody that targets B cells. And B cells are the factories in your body that produce antibodies.
So the logic is, if the factory is making bad parts...
You shut down the factory.
But wait, you're taking a patient who is already riddled with severe infections, and you're suppressing their immune system even more.
That is the paradox. It sounds completely counterintuitive, almost dangerous.
Well,
you are nuking the B cells of an immunocompromised person.
But
the goal is to stop the production of that specific autoantibody that's blinding the rest of the immune system. If you can lower those levels, the Captain Interferon-gamma can finally start shouting orders again, and the macrophages can wake up and start fighting.
it's an incredibly high-stakes balancing act.
Incredibly high stakes. But for many patients, it's the only thing that works.
It's just wild complexity, and yet, looking at how the media handled this, you'd think it was a script for a zombie movie.
Ah, yes, the AIDS 2.0 narrative.
This really got under my skin. I was looking at headlines from a few years ago. You had websites literally calling it AIDS 2.0. The Epoch Times ran with apparently highly contagious AIDS-like condition.
It's a textbook example of irresponsible medical journalism. It's scientific illiteracy weaponized for clicks.
It's fear-mongering, plain and simple.
It is. And it's so dangerous because it conflates two things that scare people: AIDS and contagion. By calling it AIDS 2.0, they imply a death sentence, and by calling it contagious, they imply a pandemic.
Which isolates the patients even more. I mean, imagine having this rare autoimmune condition and suddenly your neighbors are afraid of you because of some headline.
Exactly. We have to give credit to the experts who pushed back. The Daily Beast ran a piece quoting Dr. Kent Sepkovitz, who practically shouted from the rooftops, "This is not AIDS 2.0.
A necessary correction.
He had to explain that just because the symptom is an opportunistic infection, it doesn't mean the cause is a contagious virus. It is crucial to understand that. You are not going to catch anti-interferon autoantibodies from a handshake, the biological impossibility.
It really highlights how careful we have to be with language. But, and this is a big but, while the media was busy getting it wrong, the scientific community was quietly finding a connection that turned out to be hugely important. And this brings us to the so what of this whole deep dive.
This is where the story shifts. Up until now, we've been talking about a rare regional disease, a curiosity. But then 2020 happened,
The pandemic.
the COVID-19 pandemic. And suddenly, researchers noticed something strange. We all know the pattern. Most people got COVID and had a bad flu. But some healthy adults, people with no pre-existing conditions, were crashing.
Ending up in the ICU.
Right, with severe pneumonia, and many were dying. And doctors couldn't figure out why.
And I'm looking at the study here. They started looking at the blood of these severe COVID patients. And what did they find?
They found the exact same mechanism we've been discussing.
No way.
A significant percentage of those patients with life-threatening COVID had high levels of anti-interferon autoantibodies. Their bodies were blocking their own interferon signals.
So the same sabotage mechanism that drives this rare Southeast Asian syndrome was actually a huge factor in making COVID deadly for a chunk of the global population.
Exactly. Interferons are the body's primary defense against viruses. If you block them, the virus replicates unchecked. It turns out that this rare mechanism, it wasn't so rare after all. It was just hiding, waiting for the right trigger. In this case, SARS-CoV-2.
That is a Rosetta Stone moment.
It validates the entire field of rare disease research. You might look at this syndrome and say, why spend money studying something that only affects a few thousand people?
Yeah.
But by studying that edge case, we learned how the immune system fails. And that knowledge gave us a massive clue to understanding a global pandemic that killed millions.
It's humbling. It really changes how you look at healthy people. You might walk around feeling invincible, but you could have these autoantibodies or the potential to make them just sitting there.
It forces us to rethink the very definition of immunocompromised. We used to think it was a binary thing. You either have a disease or you don't.
Right.
But this suggests there is a whole spectrum of silent vulnerability.
Oh.
You might have a chink in the armor regarding interferon that never, ever matters until you meet a specific mycobacteria. or a specific coronavirus.
And then the drawbridge comes down.
And you don't even know why. It highlights that the immune system is not just about strength. It's about regulation. It's about the general being able to shout orders. If that one signal gets crossed, the whole fortress can fall.
So let's bring this all back together. We started with a mystery. Healthy adults, 30 to 50 years old, suddenly losing their immune defense.
We discovered it's an autoimmune mutiny antibodies blocking the captain, interferon-gamma, allowing common bacteria to become deadly.
We learned it's a genetic puzzle, concentrated in Southeast Asia, linked to certain genes, but triggered by the environment later in life. Not a contagious plague, despite what the headlines tried to sell us.
And finally, we realized this obscure mechanism is actually a fundamental key to understanding human immunity, linking a rare syndrome directly to the mechanics of severe COVID-19.
It's a perfect example of why we do these deep dives. You pull a loose thread on a rare sweater, and you find out it's connected to the fabric of everyone's health.
It certainly makes you appreciate the days when your signaling proteins are all doing their job correctly.
Absolutely. Before we sign off, I want to leave you with a thought that's been nagging me. We talked about how this condition is genetic but not heritable. A loaded gun waiting for a trigger.
The dormant instruction concept.
Exactly. It makes you wonder if the code for this immune collapse is hiding in the DNA of some people, just waiting for the right environmental key to unlock it. What else is in there? What other dormant instructions are hiding in our DNA right now? What other switches are sitting there in your code or mine, just waiting for the right virus, the right chemical, or the right environment to wake them up?
That is a question that biology is only just beginning to answer.
And on that slightly existential note, thanks for diving deep with us. We'll see you on the next one.